Now, is it just me, or does anyone else think that it's odd that Medicare is retroactively taking money away from us from 5 years ago based on a premise that we should have known, while simultaneously asking us to participate in a physician documentation template today? How could we or the physician have known if they're just now developing the template? And if the physicians were supposed to have this information in their chart 5 years ago, why was there a need for a Dear Physician letter 3 years ago? And if they got the message then 3 years ago, why is there a need for this template now? The very least that they could do is edit the recoupment notices to be accurate, strike out "you should have known," and replace it with something accurate like "you will be told in the next 5 years why you were not entitled to it." Ever wonder why it takes so long to see your doctor? Physicians don't heal people from behind their desk. We all know it. The more time they can spend with their patients relates to better health care. This phenomenon is not just relegated to the physician. Hospitals, nursing homes, and all other specialties in medicine are absolutely crippled by this paperwork. Now, this isn't a phenomenon that's unique to the medical field, but let's take a look from the primary care physician's perspective. Now, this guy's a smart guy, but he's not an expert in orthopedics or cardiology, radiology, or even pathology. No, he must look to others outside of his knowledge base to continue his care. They in turn see the patient and report back to him. But let's take a closer look. This referring physician needs information on the patient's blood work. So a prescription is written to an independent lab, which is CMS reimbursed. They perform their work, report back to the doctor, and the doctor now has a detailed analysis of the patient's blood. Another patient needs X-ray, MRI, or a CT. The doctor writes a prescription. It's CMS reimbursed. They perform their task and report back to the doctor. We're all familiar with this process. But there can be a problem when the doctor owns part of the entity that he's referring to. The Stark laws were developed to cover this type of financial conflicting interest, but they've been overdeveloped to an incredible degree. I chose these two referral examples because they never encounter the term evaluate and treat. The physician must supply all of the data needed for them to do their job. We, on the other hand, in the prosthetic industry, have worked on an evaluate and treat relationship with referring physicians for not just years, but decades. A prescription with evaluate and treat written on it is a physician's way of admitting that he doesn't know what tests need to be endeavored and does not know what action is needed after that. He is asking for a prosthetic diagnosis. Whether CMS likes it or not, we are the prosthetic diagnosticians. It's kind of ironic that they'll pay us for diagnostic devices too, huh? We cannot allow CMS to pretend that this relationship never existed, and further, that doctors ever knew or dictated prosthetic design. The Dear Physician letter introduced 3 years ago was done in a complete ignorance of this relationship. But what happens when this referring physician needs an evaluation for an amputee that needs a prosthesis? He writes the appropriate prescription that's not covered by CMS, and then the prosthetist does the report, but it has no place in the referring physician's records. How do we get this information from the expert back to the physician? They say we have a financial interest because we can basically write our own ticket. This is not an issue of the doctor owning part of the referral. As a sidebar, I'd like to say that in the Middle Ages, as many as 50,000, that's right, 50,000 women were burned as witches. The relative point here is that when you start hunting witches, everything starts to look like one. It clouds your judgment, and you overlook the obvious. So the referring physician has to do this prosthetic evaluation that he knows nothing about. CMS has overlooked a mechanism that they already have in place, and prosthetists are running so scared that survival is clouding their judgment. Physical therapists can do this evaluation, and it's CMS reimbursed. We've been using this method in my facility now for a year, and this is what my physician is supplied with. He gets an exhaustive report that's designed around the template that we're talking about today. It's ICD-10 compatible. The physical therapist has no financial interest. The prosthetist gets a second opinion, and the doctor gets a third opinion. This is a win-win-win scenario no matter how you look at it. We all agree that this information needs to be collected, but it needs to be collected by someone that's paid to do it and focus on it. It simply can't be the doctor, not for the entirety of this information. So you see, we already have the answer. It's already in place. Each one of these doctors has the same referral concerns when it comes to prosthetics. This is where we're headed. Are you having trouble getting fit with a prosthesis? No, I'm having trouble finding a physician that would write a prescription for one. Last week in Phoenix, I've had a patient tell me that her doctor said, I will agree to amputate your leg, but under no circumstances will I write a prescription for a prosthesis. You can get your general practitioner to do that, but he's not going to do it either. So now, let's play a game with me called You Be the Physician. Let's be empathetic and wear his shoes. It's 7:30 a.m. and you just finished rounds that you started at 6 a.m. at the hospital. You just arrived at the office to find that you have 43 patients scheduled today. Many of these patients will need drug prescriptions, blood tests, x-rays, MRIs, physical therapy referrals, orthotic and prosthetic referrals, etc. You have a minimum of 5 letters to write on behalf of workman's comp and other claims for patients. You've just been told by your nurse that one of your unstable patients has called and is en route to the emergency room and needs your attention. You've also been informed that at 4 o'clock today you have a deposition with one of your patient's attorney about God knows what. You've also been informed that there are 2 drug reps waiting to see you if you have a moment. And to your horror, you notice that 3 of your patients on the schedule today are amputees and will need prescriptions for prosthesis, so you must prepare functional level assessments for each one of them. Now I'm going to read the template that's being developed by CMS for physician documentation. I challenge you to watch this video in its entirety until I finish reading the template that the physician is going to have to complete 3 times on this day alone. If you can't stay with me until I finish reading them, then I win. It stands to reason that this approach is not logical, reasonable, and certainly not sustainable. If you do make it through the reading of this template and you feel like it's justified given the physician scenario, then everybody loses. The next time you're in a physician's office waiting for 2 hours to be seen, remember whose fault it is. I guarantee you that he's never behind those doors twiddling his thumbs. So here is the suggested clinical template that we're talking about that's quickly becoming this. Now in this game, remember, you're the physician. It's 5 o'clock and you finish seeing patients and you're late for your daughter's piano recital. Chief complaint. State the beneficiary's need for an initial or replacement prosthesis. History of present illness. Describe the beneficiary's current medical conditions that affect ambulation, such as congestive heart failure, chronic lung disease, arthritis, etc. Describe the beneficiary's lower limb amputation leading to the need for a prosthetic device and its etiology. Describe any current problems or complications with the amputated limb. Describe any past complications with the residual limb. If this is an evaluation for a replacement of an existing prosthesis, then we're going to need further information. Describe how often and how long the beneficiary uses the current prosthesis, if applicable, each day. Explain the reason for a replacement and any change in prosthetic requirements. Okay, I'll speed it up. Describe the beneficiary's activity level, transfers, ambulation, balance, endurance, and strength, and any functional limitations relating to ambulation. Describe any impairments of the non-amputated limb or limbs. Describe the beneficiary's motivation to ambulate and general desired ambulation goals, including vocational requirement and athletic goals beyond simple locomotion. Hang in there with me. Past medical and surgical history. List the beneficiary's medical condition and previous surgeries. List the beneficiary's current medications. Social history. Describe any current or anticipated vocational, therapeutic, exercise, or athletic activities that demand prosthetic utilization beyond short distances not already noted. Describe any environmental barriers, example, number of steps into the home, number of steps within the home, type of home, tri-level, 2-story, etc. Navigation of multiple flights of steps, farm fields, construction sites, blah, blah, blah. Does the beneficiary require assistance to don, doff his or her prosthesis independently or transfer, ambulate independently, with or without mobility aids? Describe the availability of caregiver assistance, and if applicable, any reliance on caregivers for ADLs, which stands for Activities of Daily Living. I know this acronym because I'm familiar with CMS's website devoted strictly to their acronyms, all 4,600 of them. Don't forget this website because you won't be able to remember them all. Now let's review the symptoms. Describe any symptoms affecting ambulation. Constitutional. Describe any recent change in weight greater than 10 pounds. Describe any medical or surgical procedures planned that will affect the beneficiary's rehabilitation potential, including revision of the residual limb. If applicable, describe type of procedure and expected recovery time. Describe any significant change in the beneficiary's rehabilitation potential during the last 6 months. Describe any current use of power mobility device, cane, walker, or wheelchair. Halfway there. I'll have to speed it up again, but here's some audio help. Is the beneficiary physically I hope this is illustration for blind entities. Describe the beneficiary's choice of or rehabilitation potential. Does the beneficiary require use of some option? If yes, then specifically, duration, does the beneficiary use of performing RDLs, which is mobility activities daily and non-related? If yes, describe the ideals of the beneficiary short breath and or outside home with some option if required. Describe the dimensions of these options. How the choice of breath, performing RDLs. You're great. Just hang with me. I guess these times are being reused in your phone. Describe the beneficiary's systems that increase her rehabilitation potential. Describe the beneficiary's increased heart rate, palpitation, pain, etc. that occur or worsen the beneficiary's potential performs EDLs and with some option if required. Describe the beneficiary's taking the past that work or failed to alleviate these symptoms. Musculoskeletal. Describe the beneficiary's musculoskeletal symptoms that affect rehabilitation potential. If the beneficiary's falls, detail they occur. Reason the beneficiary believes that she or he fell, frequency of time of falls. Know whether the beneficiary is able to provide sustained same position without help another person after fall. If the beneficiary experiences joint pain, describe signs, symptoms, decreasing motion, crevice, laxity, etc. that occur or worsen with RDLs, specifically describing impairments or disabilities of the non-amputated limb. Describe the management of the beneficiary's chronic pain symptoms, including use of analgesics, particularly drugs. Describe the abnormality, strength, or coordination of RDLs. If we thought the room research enough, neurological again. Describe neurological symptoms restricting RDLs such as balance disturbance, peripheral neuropathy, baseline functioning, gait abnormality, etc. SIM. Describe ECM, also loss of integrity and ideology. Cognitive behavior psychiatric. Describe any complaints, cognitive impairment, rehabilitation. Physical exam. Provide quantifiable objective measures, test of the beneficiary's physical condition. Constitutional. List height, weight, blood pressure, pulse rate, and respiratory rate at rest. Eyes, document visual acuity. Respiratory. Document respiratory exam at rest, oscillation, pulse, respiratory rate, and SpO2 at walking maximum distance possible around up to 50 feet. With current visibility device on watch required. Document distance, stimulated pulse, respiratory rate, and O2 saturation. Document literature, respiratory, for example, use of accessory muscle and muscle contractions. With mobility aid used, yes, described. If something O2 is used, this configuration, notice the weight. Good at 6 walk test and document results. Hopefully this will remember when the patient in the office, or you finish it anyway. Cardiovascular. Document cardiovascular exam, including jugular decision, lower extremity bleeding, and pressure change applicable. Musculoskeletal. Document upper extremity, lower extremity, individual muscle group, strength from 0 to 5. And this is mobility related activities daily and RDLs. Document any abnormalities, normal emotional architecture. Example, swelling, erythema, substation, contractures, neurotoxic scans, CCL, and next page included. Document condition, length, shape, etc. of beneficiary delivery. Document beneficiary's ability to transfer, include use of current mobility aids, and level, resistance, and transport, and or change from position. Describe beneficiary's aid with use of current mobility aids. This is the contractual ability earlier. Neurological. Recording neurologic abnormalities and rehabilitation potential. Skin. Describe current areas of wounds, edema, scarring, or stasis with rehabilitation potential. Psychiatric. Document beneficiary's mental status, judgment, insight, and memory. Beneficiary assessment. Medical documentation submit CMS to support claim. Document beneficiary's current functional capabilities and or rehabilitation potential. Based on this examination, indicate beneficiary's anticipated functional activity, achievable by properly delivered prosthesis within context of his or her overall medical problems. Please keep in mind the activity level supported by this exam must be consistent with the level of device delivered to the beneficiary. Plan. Based on this assessment, indication plan for satisfying beneficiary's prosthetic requirements. Well, you made it. But you can't go home yet, because you still have 2 more to go. And if you think that this is even remotely possible to write one prescription, then just remember these 2 guys. And remember this physician, and now you understand where he's coming from. This is going to damage patient care and prosthetics worse than anything in history. But wait, there's one more thing that you have to do as a physician before you can go home. You have to prescribe one of these $250,000 drugs for one of your more critically ill patients. And look at the paperwork that you have to fill out. When you compare the cost of these drugs to the cost of prosthetics, it's clear that we're being persecuted in prosthetics. Now that you've put yourself in the doctor's shoes, you know that this information isn't a form that's just yes and no. Each question starts with describe or outline, or asking for some sort of a test to be performed. This is a gargantuan amount of data, and it can't possibly be collected this way. Now that you've worn the doctor's shoes, I'm sure you'll agree.